This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Zaffer here. Welcome back to the Alert Medic 1 podcast. We're good. We're rolling.
Hey, what's up, everybody? Good evening, good morning, good afternoon, whatever time frame you find yourself in. We've got a really special episode of the Alert Medic 1 podcast tonight. We have Dr. Qassim from Philly. He's going to talk to us about some trauma stuff. Doc, why don't you go ahead and give us a quick background, kind of where you're at, where you came from, and what are you into these days?
Sure. Yeah. Well, thanks a bunch for having me. It's really great to be on the podcast and talking about stuff that everybody on this group is interested in. So I've had kind of a non-military, military brat type upbringing. I've grown up all over the world, trained in England before coming over to the States. And in England, I was really involved with a lot of operational EMS as a EMS physician. I came over to the States, was in Baltimore for a while, did my surgical critical care fellowship at shock trauma. And combining that with my emergency medicine background, I do both emergency medicine and surgical critical care up in Philadelphia at University of Penn now. So that's kind of my training background, and my professional interests really revolve around trauma care, trying to improve outcomes, in particular, trying to bridge that gap from scene all the way to the ICU and what we can bring to the patient, making these tiny marginal gains to improve outcomes for our patients.
Excellent. So to kick off that conversation, I'll start with this. Most of us know that kind of by the end of the conflicts in Iraq and Afghanistan, our casualty survival rate was something like 96, 97%, depending on which paper you read. Meaning that, if you were a soldier wounded in combat, particularly in the Ranger regiments, right? That's where most of our data was coming from. You had a really good chance of making it home. There was a directive that came down from strategic commands to focus on reducing preventable death on the battlefield to zero, if at all possible. And they seemingly the military seemed to have conquered that problem with a couple of exceptions. I think the one thing that they just couldn't get over was non-compressible torso hemorrhage, right? And we're seeing this, the same thing in the civilian EMS world, and it accounts for a significant portion of that 3 or 4% of combat fatalities, of which neuro injuries and complex blast trauma and all that other stuff comes from. The same kind of rings true in civilian EMS. Civilian trauma systems we can only hope to touch 97% survival, right? We have a completely different patient population, completely different mechanisms of injury and whatnot. But correct me if I'm wrong, Doc, but there's a similar directive. I don't want to use that word, but there's a similar push to focus on zero preventable deaths from trauma in the civilian world. And we seem to face the same seemingly unconquerable hurdle of non-compressible torso hemorrhage. And, I'm going to kick it over to you with a question of, so what is preventable death, and what are we doing? What do we have in place now to accomplish this? And what is EMS doing to have the largest impact on this?
Yeah, it's a great question. And I think one that really continues to vex anybody who's involved in pre-hospital and in-hospital trauma care. So you're quite right. It's, when you're talking about deaths, there's some deaths that you just can't do anything about. And those are typically the ones that have some sort of massive injury and will typically die on scene within seconds or minutes of the event happening. And, there's things like, they'll have, say, a massive aortic disruption or something like that, that they just can't survive no matter what you do. So those are non-preventable deaths, just from the injury mechanism. Now, preventable deaths are patients who I think about them as patients that shouldn't die. They are almost giving you the opportunity to save them. You failing to save them ends up causing their deaths. And so they have maybe bleeding in areas that are challenging to address, but potentially can be addressed. And we have to figure out a way to be able to get the care that they need to them fast enough for that to improve outcomes. And this was really looked at kind of around the time of the shootings up in Connecticut, where the school was shot up. A lot of kids ended up dying, and there was a real initiative to kind of move some of the lessons that were being used in the military out into the civilian world. And this kind of brought the Stop the Bleed campaign. It brought tourniquet use into pre-hospital care and even in-hospital care for injuries that were amenable to tourniquets. And it also kind of spurred a paper that came out from the National Academies of Science that showed that if they looked at the data for 2014, so almost 10 years ago now, there was about a 20% potentially preventable death rate that they found. And the majority of those were from hemorrhage. And actually, the number and the percentage may be a little bit higher. There's other papers that kind of quote closer to 30%. And so if you think about that, that's about 1 in 3 of every severely injured patient that has a potentially preventable problem that really shouldn't be dying. And who are those people who will typically die? Unfortunately, they're usually young, often the breadwinners in their communities or their families, who now, for one reason or the other, have faced some calamity and end up dying from it. When, if we maybe look at things differently or approach their injury differently, they would have survived. And so that's really kind of been a big paradigm shift in our thinking over the last 10 years. How do we address that bleeding? So where's that bleeding coming from? Sure, we talked about head injuries. Head injuries are still really challenging to address. And I think even in the military, if soldiers who were suffering from devastating traumatic brain injuries, they didn't do well. And civilian world is the same, massive head injuries, such a variable outcome on them. So put them to one side. But the other group that we really need to focus on are those with what's called non-compressible hemorrhage. So if you look at, say, tourniquet use, so those are typically applied to extremities where really you could put direct pressure on those compressible sites and then are essentially kind of stopping the blood flow to those compressible sites. But the non-compressible areas are areas like the chest, the abdomen, the pelvis, where you can't put a tourniquet on, and it's very difficult to apply direct pressure to. And those are the sites where bleeding can be really challenging. It can be really fast, and it causes death fairly early if you don't control it. So that's kind of been the focus of a lot of work in both in-hospital and pre-hospital work in the civilian side.
So would you say that we have a time problem, or we have a resources, equipment, tool? Do we have a silver bullet problem?
All of the above. And I think, it brings to focus the challenge and the difference from, what you do in the military, where even though you have 3 or 4 major branches, really, there's some crosstalk, and generally, if one branch says do things one way, that whole branch will do things that way. And then you look at EMS in the U.S. civilian practice, and in Philadelphia, they'll do things one way. Out in the burbs, just a few miles from here, they'll have different protocols and do things different way, and they'll have a different experience. And that's the real challenge, I think, logistically, of being able to kind of draw up a blanket protocol or approach to being able to address this. So that's the first thing. The other thing I think you hit on was time. And it is certainly a lot faster that these patients are dying from non-compressible hemorrhage. So typically we say the majority of deaths in the first 24 hours from trauma occur from hemorrhage, but those from non-compressible sites really happen much earlier. Some papers have put it like the first 6 hours. But there was a really neat paper where it kind of, in the title, really highlighted that time is the enemy. And they looked at patients who had high-grade torso injuries, and they actually showed that there was a significant challenge or change, rather, in the mortality rates beyond about 15 to 20 minutes from injury. And so something needs to happen really at point of care in a lot of systems, because 15 to 20 minutes is usually these patients are still outside the hospital. And so in most systems. And so it requires us to kind of think about what we're doing close to point of injury in the pre-hospital setting to kind of change the outcome and move the needle on that group of patients.
So on that topic, I'm going to share my screen and bring up this graphic, which I think every emergency medicine individual and EMS individual needs to see from your paper. If I can figure this out, I'm just going to share my entire screen.
Yeah, so if you go to it might, if you have a tab open, it does let you pick a tab.
Boom, perfect, got it. All right, so you guys are seeing this paper. I probably should zoom in just a touch or two. Doc, can you unpack? Oh, that's too close. My fault. Doc, can you unpack this a little bit for us? And I think it brings, I really think it brings to the forefront kind of the gravity of the situation that we have as far as time. You made a point that stuck with me from FAST last year, of that sometimes these patients have continuous bleeding for up to 2 hours from their time of injury. Wow. I mean, that if that doesn't get your attention, I just don't think you're human. So take it away.
Yeah, totally. So basically, this kind of lays out the timeline from injury to definitive care in the hospital, which is typically in the operating room or sometimes in the interventional radiology suite. So, usually the patient's injured. There's a time period where 911 is activated, and the response time, scene time, and then package and transport, evaluation in the emergency department, and then moving on to definitive care in the operating room. And so the way a lot of trauma systems are created around the United States is that there's been such a mentality, especially I would say for like penetrating trauma, that you should just grab these patients and run to the nearest appropriate trauma center, and then they'll get all the care there. But in reality, anybody who works in pre-hospital care knows that, there's a lot of time that you sometimes don't account for. It's not just how to get from point A to point B, but you arrive on scene, maybe the scene's a little dangerous. You have to identify where the patient is, get to the patient, do your evaluation. Packaging takes time. Loading takes time, especially if you're in an airframe. Maybe the LZ is a little bit further from the actual accident scene. And then you have to take off and land and offload at the hospital. And all those time factors are never kind of put into that A to B transport. Oh yeah, the transport time is only like 15 minutes. Actually, yeah, but another 10 minutes gets added because you have to do all these other things. And then they come down to the emergency department, they get evaluated, another X amount of time passes before they get to the operating room. So all this time, these patients are bleeding because nobody's taking care of kind of arresting that hemorrhage. And the way a lot of systems have been, not even advanced interventions like we'll talk about in a sec, like restoring blood volume, are happening in the pre-hospital setting in a lot of these systems. And so you have to wait to the hospital. And so when Holcomb kind of looked at these trauma systems across the United States, saw that the median time to be able to get these patients from point of injury to their definitive hemorrhage control was approaching 2 hours. And so all this time, these patients are continuing to bleed. And so it's no wonder that, outcomes, especially for patients with non-compressible torso hemorrhage, have not really changed in decades. Despite all these fancy things we hear about in the hospital, sure, it's good for patients who come into the hospital and they're not in shock. But when you look at the data for patients who arrive in hemorrhagic shock, their outcomes haven't changed despite all these gadgets and gizmos that we have now in the hospital. And so that should really put you into focus, right? That, there's the
Yeah.
system really isn't designed to get these people quickly to definitive care that they need. It's and that's where we need to kind of look at what we need to do to change to improve outcomes.
Yeah, correct me if
Doc,
I'm wrong. Go ahead, Josh.
so it's interesting you bring up this timeline because this is like so crucial. This is something that, like Cody said, this needs, like, if you're watching this, pull it up on your Spotify, watch this section right here with this graphic shared on YouTube, wherever you are. Take a look at this because I think a lot of providers, clinicians don't understand the amount of time that is from point of injury to definitive care. We always think about the transport time, and it was pervasive in my agency actually when we were talking about early on, and we're about to hit to the point where blood is hitting the streets in my agency. But 4 or 5 years ago, when I was talking to the guys, they're like, "Well, we have a trauma center within the county. Most people can get there within 15, 20 minutes. What they weren't taking into consideration is the time on scene, the time getting to the scene, the time from the point of injury to 911 initiation, and just not even looking at the time to scene, time to call, all this stuff. We were looking at a median like 35 to 40 minutes from contact to handoff at the hospital. And that's a lot of time not getting the definitive care, not getting blood, not getting resuscitated properly, not stopping those bleeders. And that's the portion that we, as providers, as EMS clinicians, are in control of. Everything after handoff, we don't have control of, but if we can shorten the time from where we make contact to handoff, it shortens that time. It all scrunches, it all compensates down the way, and we're able to lessen that amount of time. And correct me if I'm wrong, Doc, I could have sworn there was a study out there within the past 10 years that studied how long at a specific trauma center, I don't know which one, it took for blood to go from the bank to the patient's side. And I think they said it was like an average of like 30 to 40 minutes from point of activation to point of blood going into the patient. So we're not even talking about going to the OR. We're just talking about resuscitation in the trauma bay. So
Yeah, you're right. It does. It's if you don't have like blood available in the emergency department, then it does take that because they'll need some sort of record of the patient. Even if they release uncross-matched blood, they still need some form of a record where they need to document that for their safety purposes. So it does take a while. And oftentimes, the blood bank is not anywhere close to the emergency department. So that travel time is important. And I remember talking about this when we were thinking about bringing another intervention into our hospital, and people didn't understand this time factor, and they were always going, the operating room's right here. We can get from the emergency department to the operating room in like less than 10 minutes, and go, okay, let's try it. So we set up a simulation. We put a mannequin on the stretcher who was hooked up to all the monitors, and we said, okay, let's bring this person to the OR. And actually, by the time they transferred the monitors to the transport monitor and the nurses got ready and they got their documentation and they moved and they called the elevator, etc. Actually, it takes much longer than people think to be able to do that. And that's kind of a nice comparison that you can say to people who don't know the pre-hospital world that, we have to do similar things in the field, just in different ways, but the concept's the same, that it takes much longer. It's not just traveling from A to B, it's all the other things.
So if time seems to be our enemy here, right?
Yeah.
And we know that, and this was studied both. This has been studied both in the civilian and in the military sectors. We know that scoop and run really is not helpful. It's not as helpful as we think it is. It's this mentality of, well, if time is the enemy, then let's just get there faster. And what happens in that transport phase, or at least from arrival to drop off, is really what's super important, correct?
Totally.
And that mortality rate from hemorrhagic shock, that's something like 20, 21%, I believe, something close to that. how do we make that time work for us? It's like I look at it like being stuck in traffic, and you could sit there and be mad that you're stuck in traffic, or you could do something, listen to a podcast per se, and make that commute work for you. So how do we make that commute from the point of injury to the ED? How do we make that work for the patient? How can we influence? We can't control the time, to Josh's point. We can't control what happens after drop off, but we could do some stuff before drop off that may influence things later on, correct?
Yeah, totally. And I think, when people try to think about making change, I think they take the strategy a little bit the wrong way, because they'll say, okay, well, we have a trauma system. Maybe we have to change the whole trauma system to make things better. But actually, you don't. You have to break down your system from point of injury to definitive care and look at, how can we change maybe even one or two or three things in it, because shaving off a few minutes here or there could actually improve things in the longer term. And that's a concept that kind of came out of bike racing. That's called the concept of achieving marginal gains. And so if you shave off a second here, a second there, your biker wins the race as opposed to coming in second. So where do you do that in the journey that the patient is taking, right? So probably you can look at that time period where the incident happens and 911 is activated. And so that can be variable, right? So when does somebody realize that somebody's injured, and then how soon can they get to a call? It used to be to find a phone booth, but now everybody's got a cell phone, so they can call 911 right away. But then what happens in that time period, that 5, 6, 8, 10 minutes that it then takes for a dispatch ambulance to get to the scene? So, civilians learning to do basic hemorrhage control techniques is certainly one part that you can change, and really focusing on your community to be able to teach those skills, like through programs like Stop the Bleed and other things, similar to what we did for medical cardiac arrest, where we've encouraged bystander CPR, and certainly those communities that have taken that up have shown improved outcomes. So that's kind of one step where you can achieve some gains.
This is your concept of spontaneous responders, right?
Yeah, exactly. Yeah. And actually, I give credit to my colleague, Christina Hernan, who was one of the physicians at the Boston Marathon bombing. And she was really taken aback by the fact that she really struggled with what to do in that time period, because everybody kind of, the way she tells it is like everybody teaches you on these life support courses, you have to wait for the scene to be safe or assess the scene to be safe, but clearly the scene was not safe at that time. And so people are dying in that time period. So what can you do? And she's really kind of pushed that concept forward. So that's one thing that you can do, and that involves kind of investing in your community and seeing what you can do to teach lay people how to respond in these circumstances. And then the second one is, can you provide meaningful intervention in that time period? The time that you have to transport, say crossing a physical distance, you can't really do much about that or change a lot about that, because that's just the geography. And certainly in the United States and some parts of the United States, that might be a lot more challenging. And that's just not just if you're in a rural community. It could be if you're in a dense urban environment, you face a lot of traffic, even on lights and sirens, you still struggle to get to the hospital. So what can you do in that setting? And that's where you can address the shock state. And so what do we do in the hospital to address the shock state? Well, we administer blood instead of crystalloid, and we try and use means to stop hemorrhage. And so what will that working in the pre-hospital setting? We're starting to see more and more evidence to support the use of pre-hospital blood. And there's programs that are internationally out there as well as here in the United States that have clearly shown the feasibility of bringing blood into the pre-hospital setting. So you're addressing the shock state, which is a big part of contributor to mortality. The longer you leave these patients in the shock state, the more likely that shock is going to be irreversible by the time they get to the hospital. And we've seen those patients, right? We seem to be able to do everything right for them, but they still die in the hospital. And that's because their shock has gotten to the point that no matter what you do at that point, they're not going to survive. So bringing blood pre-hospital is one huge, I think, low-hanging fruit that we can do, and that systems are already doing now to provide meaningful intervention en route to the hospital. What else can you do? We talk, several systems about decompressing tension pneumothoraces, putting tourniquets certainly on compressible sites of hemorrhage, but also using things like these new hemostatic gauzes that have come out from the military to pack wounds, and that can be used in gunshot wound tracks or stab wound tracks. You can pack those wounds. Not all services are doing that. That's a simple way that you can provide a meaningful intervention for hemorrhage control in areas like the abdomen, etc. And then you talk about more fancy stuff, such as compression devices for abdominal hemorrhage. So they have things like the abdominal junctional tourniquet, and then even fancier things like Reboa, which in the US hasn't really come to light, but probably the London Air Ambulance Service, probably the one that comes to mind to most people of bringing that intervention closer to the point of injury to provide temporary hemorrhage control while they get to the hospital. So the question is not that you stop taking people quickly to the hospital. So you still want to maintain that trajectory because you ultimately have to get them to a surgical capability to be able to provide definitive hemorrhage control. But the point that we put in the paper is that en route, you can do a fair amount of stuff that will provide meaningful intervention to that patient and may just improve their outcomes. And that's what we changed the term scoop and run to scoop and control, where we're actually still maintaining that trajectory, but controlling some processes in the dying process to prevent poor outcomes.
I'm writing that one down. Scoop and control.
So, Doc, I have maybe a devil's advocate question here. And while I completely support everything you're saying, I just want to kind of maybe head off maybe some of the listeners and some of the followers that may bring up a certain piece of this. The scoop and run. Now, you're from the Philly area, and the Philly area is famous for saying that more trauma patients survive getting thrown in the back of a squad car and dropped off at the ER or at the trauma center. Can you speak to that in the scoop and run mentality? Because I know there's some people that are pretty diehard on that statement, the statistics. So
yeah, so really unique to probably the whole United States. Philly is probably the highest volume place where the police actually in their manual have it written that if they come across a scene of a penetrating trauma, then they should transport that patient immediately to the nearest trauma center. But let's look at that a little bit closer. So the layout of Philly. So we're in the top 10 in terms of population in the United States, but we have, for our population, we have 4 adult level 1 trauma centers and 2 pediatric trauma centers. So probably I'd say a few more than we actually need, but nevertheless they're there, and they're scattered strategically around the city so that you're never really super far from a point of injury. So that's one thing in our geography. And then number 2, it's a lot of times where we're situated can be pretty close to the scene of the incident that's happened, so the shooting or the stabbing. And so the way that 911 calls happen in the Philly area is that the police dispatch will initially get the call, and then they'll transfer that to fire rescue if it's primarily medical. And so the information gets to police first. And so if they are aware of that, they'll immediately dispatch. And so they'll often be at the scene before medics have been perhaps even dispatched. And so for them, not being able to provide any additional intervention to bring those folk immediately to the nearest trauma center because of the geography, they're usually not more than 5-6 minutes away. And so in some ways it makes sense for them to do that. And in systems where, or an incident happens just a block away from the hospital, probably it's better just to bring them quickly to the hospital and continue care there rather than work them on scene. But that's not the reality in most places around the United States, right? So a lot of places will have one level 1 trauma center, perhaps for their immediate area. A lot of places are well over 45 minutes away from a level 1 trauma center, and that's the reality of the way that trauma systems and trauma centers have been set up in the United States. You look at some of the Midwest and the Northwest states, and there's huge geographical challenges there. So clearly, a cop is not going to help out there to bring that patient to the scene. So I think, going back to how disparate EMS systems are around the United States, we can't use a one-size-fits-all model. Now, having said that, so let's look at New Orleans. So New Orleans has been, for the last year or two, have gotten their medics to give pre-hospital blood. And a lot of challenge came to that, where they said, well, you're an urban center, you're seeing penetrating trauma, there's a level 1 trauma center that's right in the city. And so why not just you should be doing scoop and run for that. So they decided, okay, well, we're not going to do that. We're going to give blood, and let's see what happens. And they are a real lesson in achieving marginal gains, I think, because they decided that they would set up a system where they would have they would respond to their penetrating traumas, and they would, if they met certain criteria of them being in shock, they would administer 1 or 2 units of red cells, I think they were using at the time. And so they looked at the data, and they found that once they'd implemented it, their mortality in an urban trauma system for penetrating trauma was reduced as compared to before. And in fact, when you talked about the time it takes for blood to come from the blood bank down to the ED, they showed that even though their scene time was a little bit longer, the actual time of them having started their meaningful intervention was shorter, even including that longer scene time, was shorter than if the patient had arrived to the hospital and then waited to get the unit of blood from the blood bank. So that's, again, kind of understanding the logistics of EMS world and what it involves in seeing. But remember, the factor that you can't change is the distance, but the factor that you can change is what you do in that distance. And so they decided that they're going to give blood early to that and have actually moved the needle significantly on their mortality. So I would say that's like flies in the face of this whole scoop and run for penetrating trauma in an urban trauma system. So I'll use them as an example there.
That makes complete sense, by the way, Doc. I mean, like, I'd be hard pressed to not see how you are getting those actual marginal gains, because if you're bringing a patient that's properly, or at least the beginnings of a proper resuscitation using the blood, packed red blood cells, whatever you are using, it cuts down on what the trauma bay or trauma team has to do, because you're already starting them out at like a couple steps above where you were a year before when you weren't doing this.
Totally.
And San Antonio is, I'd say, the model for when it comes to implementing blood. Everyone probably knows that by now. But they're also an urban EMS system. Yes, they do have rural parts, and they work with Bexar County and other counties, and they're rural and they have blood as well. But they started urban. They've got 2 major level 1s in the city, very famous ones, and they were seeing immediate returns as well. Treating on scene with the blood, bringing this at least proper, beginnings of a proper resuscitated patient, and surprise, surprise, you're making up time. Even though you spend a little bit more time on scene doing something, you're making up time on another portion, and that marginal gains.
Yeah.
That should be the title: Marginal Gains in Trauma Resuscitation.
Right, exactly. And remember, a lot of the papers that looked at, whether you should be doing more in the field or not, were still administering like large volumes of crystalloid. And so,
Yeah.
they're not giving the right product. But now that we've evolved in our trauma resuscitation in general, we should be running those trials again to see. And New Orleans is already kind of showing that, like as a before and after kind of thing. And so other systems can certainly bring that in. And I think, of all the interventions that are out there, I think administering blood pre-hospital is something that a lot of systems can overcome and the challenges for, and actually, do good for their patient population.
I would say that of a lot of folks that I've talked to that have had to overcome those challenges, you and your team in particular in up in Pennsylvania, getting that across the goal line, that was I would say akin to a Herculean effort almost, right?
Yeah, it was. It was. We were lucky in a lot of ways. The challenge in Pennsylvania is that there is a central kind of governance of what EMS can do. So the protocols come out from out of Harrisburg from the Department of Health, and they get disseminated to different agencies. And so if you were a critical care paramedic or a flight nurse, you could administer blood in the field. If you were just a regular paramedic, not on a critical care transport service, then you were not allowed to. And so we thought that was pretty stupid because, there's a lot of places where the medics are the ones that are seeing these patients. And so a group of us across the state actually came together to kind of propose the change to their protocols. And actually, last November, we got that through. And so now it's allowed in the state of Pennsylvania for paramedics to administer blood. And that's really allowed a lot of services to say, hey, this could help our folk. And they're looking at our different systems that have been doing and trying to bring those lessons home, including right here in Philly.
Mm-hmm. And so there was an interesting thought that came to mind. I say it's interesting because, of course, I thought it was interesting. But there is this mentality that I don't think it's enough. It's not advanced enough to get blood far forward as far forward out of the hospital as possible, and that gives me this feeling that maybe we don't need a. And I wish Ben was on the conversation for this, but does every big city or does every big hospital system need a physician go team, to haul ass across city to give this thing that we have all proven that paramedics are 1,000% capable of doing, and that's administering blood.
The internet didn't
that,
agree with them, so he got cut off.
Yeah.
no,
There's controversy.
Exactly.
Yeah.
Ben's magic was halted.
He just doxed your internet connection, bud, from the ether.
Ben is always listening. Ben is always listening.
All right, go on that diatribe again so we can make it a reel and make sure he hears it on Instagram.
So the concept of pushing blood and basically beginning resuscitation at I'm having problems again, aren't I?
No, you're good.
Okay. Having beginning resuscitation as early in the treatment, access to, as soon as in the treatment chain as possible, has a pretty good impact on the patient's outcome. And where we're doing that is places like Philly and places like New Orleans and San Antonio. We're doing this with paramedics with a couple of units of blood. And the I don't want to say the funny point, but the counterpoint to this desire to have physician staff QRVs on go teams to haul ass across the city to do something that quite frankly could be left to paramedics. Not that there's equality or parity in skill and knowledge, no, but perhaps better utilize those paramedic resources.
Yeah, I think again, you have to look at systems. So, for example, I used to respond quite regularly when I was in the UK, often to major trauma and sometimes like complex medical cases. And part of the reason was what's allowed in the paramedic scope of practice in the UK. So things like RSI were not in the paramedic scope of practice. So a physician would be called upon to help with that. And then even blood administration is still not in the paramedic scope of practice in the UK. And so critical care teams, which are often physician paramedic, are called to do that. So that's one thing. And that's not all case across the United States. So there's several systems where, the medics are perfectly, are trained to a degree that they and are allowed by protocol to do drug assisted intubations and now administer blood and things like that. So, certainly for those things, I think, adding the physician to the scene doesn't make sense. But there are other opportunities for the physician to add to what is happening on scene. So certainly, I would say I'll take the example of a complex extrication. So where it's a prolonged scene time, and they're struggling to get this person out from whatever they're entrapped in. A physician can add additional skill of more complex analgesia and help with advanced airway management. And maybe some advanced interventions, if an amputation is needed or something like that. But I think the other flip side that sometimes people don't think about is the just the knowledge and experience that can be added to the scene. And I think this is especially true in larger EMS systems where sure, everybody's kind of trained to a degree, but individually, that medic may come across a really bad trauma once a year, just because of the vast number of people on the rigs. And so, sure, they're great at what they do, but maybe they haven't seen that before, and maybe their adrenaline's pumping just a little bit too much, and they're not really in the best position to be thinking as straight as they would be, say, in a training scenario. And so having a physician on scene there can help with the medical direction of the rescue. Perhaps you're so tunnel visioned into, okay, the only way we're going to get this person out is to amputate their leg. But no, maybe the physician comes on and says, hey, maybe if I really sedate this guy appropriately, maybe even tube him here and control his pain, and maybe that'll give you enough time and opportunity to be able to cut through whatever it is and get it off without us taking his leg off. And so this medically directed rescue can be a physician tool. Certainly the advanced interventions like amputation and stuff, it warrants having a physician on there. Certainly, I don't think in any paramedic protocol that I've seen in the United States. But even in the UK, I would say like 8 times out of 10, my role was to say, hey, you're doing a great job. I agree with what you're thinking. And how can I help you? And it was more that reaffirming that, hey, I know you've read about this and you've probably thought about this, but you've never seen it. And you're thinking things the right way. And it's just that additional person saying, yes, you're right. I'm here to support you, and let's get this done. And I think that in some scenes, and you guys can probably think of seeing jobs that you've been on, that having that reassurance in the middle of the night from another more seasoned person can go a long way to making sure you're doing the right thing for your patients. So I think there's a lot of additional things that a physician, especially one with appropriate EMS training and experience, can kind of bring to the scene. And I think that's where in the United States, things can be really useful. Even with the GO team, it's like, I think a lot of the times they're brought out for things like having to do an amputation or something like that. But more often than not, they're doing things like supplementing what the medics are already doing pretty well. And so, I think that's the way that you have to look at what physicians can bring to the field.
I love that. It's priceless.
It's interesting. I've obviously stayed quiet so far in this conversation, and when I was reading your paper, and we were, and we'll go into, we haven't talked about SPARC teams yet, right?
Nope.
Yeah. So after reading the paper and then I read it again to just take some notes, I couldn't help but think of a part. So I'm holding up, if you're listening, I'm holding up this thing right here. I don't know if you guys can see it. So this is probably the mother document of what we do. right? Accidental death and disability, the neglected disease of modern society. It's a massive paper that really is considered, at least from my understanding, the parent document that kind of has laid the groundwork for what everything we do today. And it was published in 1966, and I just want to read an excerpt here. So while most ambulance calls involve non-emergency cases, the justification for speeding, the use of sirens, and violations of local traffic regulations is debatable. It is a consensus of representatives of the Joint Action Program that more injuries and deaths are produced by improper control of ambulances than would be. Okay, so that part doesn't doesn't matter. Helicopters have proved so successful as ambulances in combat theaters that they should be adopted for selected use in this country. They have proven to be necessary to move physicians and equipment to the accident site and to evacuate casualties from major highways. So I was thinking about it, and especially like where we are, in Maryland, I think it's such an obvious thing to have that resource. Now, on the other side of things, I've certainly been on scenes where physicians were not appropriately, their affect wasn't appropriate, their treatment that they were providing, or the affect that you described of, hey, what can I do to help? That's a very specific type of physician, and we're blessed in Maryland and in the surrounding areas to have folks like you and other leaders that we have, but that's certainly not the case. So there has to be more effort, and your paper, this review article describes it perfectly, that there has to be proper training on the physician end, because I was listening to a lecture last week from our state EMS medical director about triage, right? Who's the best person to do triage? It's not a physician, it's not a paramedic, it's an EMT. And just like how you were talking about tunnel vision due to lack of experience, there's also tunnel visioning because of too much experience. So it's crucial that when we deploy these teams, and I know we're going to get into them, there has to be appropriate training. And when these physicians are being deployed, there has to be the appropriate training and there has to be the appropriate oversight, which, I think we all know that, it's not just physicians. The oversight thing can be one of the first things to fail. So I'd love to get your thoughts on that.
Yeah, no, you're totally right. So I think, and I would argue to say, I'm not sure how the setup is now in Maryland or other places that incorporate physicians, but a lot of places that had physicians just say, hey, let's call up the local hospital, see who's working, and bring them out. And you've seen pictures on the news of people showing up to like complex industrial scenes wearing scrubs and dance goes and like wanting to be in. Of course, us as physicians are, we're all got big egos and stuff, and we think that we're great. But the reality is, if you don't understand scene, how a scene works, what the chain of command is on scene, who's wearing the white helmet, who's got the other color helmets, etc. And you decide that, okay, only your word is gonna be taken, then you're not the person to go out on scene. And so it behooves you that if you decide that in your system you're going to bring physicians to the scene from time to time, probably worth having a cadre of physicians that one will get the experience of going out to scene, and two can get trained to not only know what to do in that environment, but also interact appropriately with other people. And that requires then multidisciplinary team working. And so, bringing docs to the fire academy or taking them out to some USAR training or something like that, so that they actually then have to crawl into a hole and go and an IV in or tube someone or something like that. That provides the level of immersion in their training that they can then build on when they're actually called out to be on scene, because you don't want them to become a liability on scene, right? And so that's unfortunately how, when physicians are brought out, I think still in a lot of places that don't have defined teams of this, that I think they've become more of a liability than anything else, but they don't, and them not seeing themselves as liabilities because they lack that training adds even more danger, I think, to the scene, and it adds more to an already stretched bandwidth of the pre-hospital team. And so I think you should look at who should respond and who should not. There's a level of fitness that might be required. There's a level of collegiality, and that's required to be able to work with teams that you probably have never interacted with before. And there's a level of understanding of what happens on a complex trauma scene in the pre-hospital setting that you should know. And so that's where I talk about it in the paper, having a select group of folk that can maintain experience and maintain their skills is really important.
What's been your most favorite EMS and physician cross training event that you've done?
Yeah, we've there's a really cool course that is run out of the UK. It's called the Attack course, which
Mm-hmm.
they do a really great job. They essentially take over this essentially like a military base over a weekend, and they create all these really interesting scenarios where people can go through, which includes like going into a deep dark hole and trying to find the victims, and they have a train that's a train carriage that's like partially on its side. So as soon as you get in, you get disoriented because it's like you're trying to climb between the seats to get to the patient. So I thought that was really a cool interaction. And here in the States, I've had some experience kind of just observing how our local USAR team kind of gets trained. And I thought that was really useful because that brings together a really sometimes a diverse group of folk who then kind of have to come together pretty quickly and try and address a complex scene as well as the direct patient management. So I like those kind of training sessions for sure.
Excellent. So if you guys are cool, then we'll switch gears back to resuscitation strategies for these patients. A non-compressible torso hemorrhage. You can't get the gauze. You can't get direct pressure on these bleeding vessels. We can push blood all up into the degree that it's all in and up back in the chest. What are some other resuscitation strategies that we can use outside of the hospital? Things like or even just offer your thoughts on things like permissive hypotension, adjunctive therapies, TXA, calcium, and all that. And
Yeah,
I wanted
if
to
I don't
bring
have
up
blood, what's number two?
I wanted
Go
to
ahead,
bring
Josh.
up permissive hypotension because I had a question, and maybe you can address this at the same time. There's a
Sure.
talk of, okay, so permissive hypotension, we usually are told 80 to 90 systolic. And there's some people out there that are referencing, hey, I think we can go lower into the 70s, maybe 60s. And the inverse of that is, well, then you have a map that is well below 65. And are we actually seeing, is that actually a good thing to drop it that low when we're not going to be perfusing correctly what we do have? So if you can tie that into talking about permissive hypotension.
Yeah, no, it's a great point. It's one that's been debated for a long time now, and I think so. First of all, we're always drilled into this map of 65, and that's kind of more coming out of the medical resuscitation sepsis literature that number kind of comes out of. And so, the trauma world, I think, is primarily kind of guided by systolic goals. But really, I think an arbitrary number, personally, for me, is challenging to use. So, say someone who's young and fit and healthy, a systolic goal of 80 or 90 might be fine. But you get how much elderly trauma are we seeing? So we're seeing a lot more than we have before, right? And all these patients are hypertensives at baseline, and so 90 for them is much lower than they're ever used to. These people live at 140, 150, and so their permissive hypotension might be 110. And so I think you need to adapt your goal to the patient. Two, how do you tell if they're perfusing appropriately? So you can use clinical signs. So some people will titrate their resuscitation to a central pulse. And so, if they've got a strong femoral pulse, then that's the goal that they want to, if they're talking to you, then that's the goal that then that their brain's perfusing. And so that might be a goal that you're using as opposed to an arbitrary number. So that might be another thing. And then people talk about, what if they have a concomitant traumatic brain injury, because we know that the lower blood pressures malperfuse the brain, and that's the secondary injury that will happen to an already injured brain. So, there's some school of thoughts that use, again, those arbitrary numbers, but they quote, like, if you have a traumatic brain injury on top of your torsion injury, then you should be going for a higher systolic goal, maybe 110, as opposed to the 90. So my bottom line on that is that look at measurable factors of perfusion, central pulse, alertness level, factor in the age of the patient, and then factor in whether they have a brain injury or not. So the other couple of things that you mentioned were TXA. So TXA in the States, for some reason, has been super delayed, where the rest of the world is using it for a long time. The Crash 2 trial came out more than a decade ago that showed, like, worldwide, except the United States, where they didn't recruit, it showed benefit in trauma. And so a lot of protocols have already utilized that. Certainly more and more hospitals, I think, are utilizing it. And now we've had data, the STAMP trial in particular, which came out of Pittsburgh, that showed that pre-hospital TXA, the earlier you give it, essentially, is the better. So, the TXA typical, the packaging says give it within 3 hours of injury, but actually the later you give it from injury, closer to the 3-hour mark, is much worse than if you give it closer to the 0-hour mark. So again, that goes to the marginal gains. So giving that early is better. And actually, the STAMP trial suggested using 2-gram initial bolus in your severely injured patients. So, and some systems are going to that. I know the military in their TCCC training has kind of advocated for that too. Calcium's an interesting one. I think it's gotten more and more attention over the last few years, and there's some really interesting papers that have come out of it, looking at calcium levels for patients who arrive in hemorrhagic shock. And a recent paper actually showed that more than half of patients, when they took a blood gas sample from them, were shown to be hypocalcemic. And so hypocalcemia was independently kind of associated with worsening mortality. And that's really because it's kind of in a lot of the processes that are responsible for how effectively we clot. And so people talk about now this lethal diamond instead of the lethal triad, where hypocalcemia is kind of the fourth element of it. But actually, hypocalcemia feeds into the other three. So if you're hypothermic, your calcium metabolism changes. If you're acidotic, again, your calcium kind of how it works at the cellular level changes. So it's all kind of fed into all of that. Thinking about calcium early is really useful to look at. But on the flip side, there was another recent paper that actually showed that hypercalcemia is just as bad as hypocalcemia. So say you have 50% of patients who are hypocalcemic on arrival to the trauma center. Oh, should we just give empirically calcium to everybody? But that could mean that 1 in 2 patients becomes hypercalcemic and that you've actually done them harm. Mm-hmm. So maybe your system has point of care testing. You could do that. You could think about it. But I would say if your patient's like crumping, probably the benefit of giving an amp of calcium is probably there. And so certainly if you've given the blood and they're still kind of circling the drain, you can add the calcium to it as another adjunct. So that's my thoughts on kind of using pre-hospital calcium.
Do you think it's important that we distinguish between, trauma-associated hypocalcemia and transfusion-associated hypocalcemia?
Yeah. So these patients that they measured the low calcium in was even like regardless of whether they gotten any blood in the pre-hospital setting. So even in systems that didn't have pre-hospital blood, they still showed that there was a significant percentage that had hypocalcemia on arrival. So it points to the fact that the process of bleeding itself, and it might be just the fact that that's causing them to become hypocalcemic. So, but it's an important point that you raised, because those places that are using component therapy in particular, especially once you're giving like more than 4 units, you need to be, the practice in the hospital is usually when after your fourth unit you give an amp calcium, because the citrate in the packed red cells does lower your calcium by chelation. We're not quite sure how much that equates to whole blood. Some people say after 4 units of whole blood, maybe you should be thinking about it, but we're not quite sure because there's much less citrate in whole blood than there is in component red cells. So that's something that's probably needs somebody to look at it more closely. But certainly if you're giving more than 4 units pre-hospital, and I think there's not that many systems that are probably carrying more than 2 units at a time, but if you are, then certainly think about it after that 4th unit.
Josh, I cut you off, man. I'm sorry.
No, yeah, we're good.
I had a question that came up while you guys were talking about permissive hypotension, and I have this this analogy or this metaphor that I think of when I think about this. It's kind of like when you're fighting a wildland fire, you're setting a backburner and you're using fire to fight fire. It's almost like you're using shock to fight shock in this case. It's something, I mean, just by definitions, right? Is there a point or is there a dose of permissive hypotension at which case we should probably start resuscitating to go back the other direction? And I'm talking about a dose in time, not necessarily low systolics or MAPs.
Yeah, so how long are you going to sustain them at a low pressure, I think is the question you're asking. I guess especially
Yes,
in
yeah.
systems that have longer transport times, or even if they're on scene for a long time. And I think certainly if you look at how resuscitation works in the hospital, so a patient arrives in the emergency department while they're having their evaluation and their initial resuscitation, you want them to be low, and the theory is that the higher they go, they'll pop any clot that's there, and so that's why you want to keep them low. But actually,
Right.
That doesn't extend into the point where they get into the operating room, because at that point you're not you're wanting that perfusion of organs, so actually achieving that resuscitation whilst kind of controlling the bleeding definitively. So the evidence kind of has really been looking at lower blood pressures before they get into more hands-on resuscitation. And I think probably, as you get into the longer transport times, you want to be thinking about kind of maintaining certainly your cerebral perfusion pressure. And I think, again, you can use that as your guide in that time to make sure that they're resuscitated enough that they're mentating. And I think if they're mentating their brain, or if they're perfusing their brain, then probably they're perfusing the other important organs as well. And so that can
Sure.
be your guide there. So don't run them all at 70 for like your 40-minute transport back to wherever you need to go.
I'm glad that you talked about transport. So in the critical care phase, the critical care transport phase, so we've gone out to XYZ hospital and we're coming back to UPenn, or we're going out to the shore and we're coming back to shock trauma. Does permissive hypotension, should that even be in in our resuscitation strategy, post-op or post-damage control resuscitation at the sending facility?
I don't think so. I think if if you're picking up a patient who they've operated on and they've achieved a degree of hemorrhage control, I think you can be a little bit more liberal as long as you're sure that there's not any active bleeding ongoing. So if they struggle to kind of get bleeding control, that's one thing. But a lot of times what you're picking up then is a patient who's remains in shock or is probably more coagulopathic as opposed to actively having surgical bleeding. So it's almost like the medical bleeding, some people say, where they're oozing out of their IV sites and things like that because they can't clot now. And so I think you do a disservice to them to keep them at too low a pressure and use that permissive hypotension concept, because at that point you're trying to recover what has been damaged. And so more than likely, because of the hypovolemia, they developed a kidney injury because of poor perfusion there. So you want to make sure that you're trying to restore that. Gut perfusion and other organs as well. They may have a shock liver or something. And so you want to maintain enough of a perfusion to all those organs as part of the ultimate resuscitation. The other thing I think that we're learning more and more about, and people have been kind of focusing on this in different spheres, is that especially in the super shock trauma patient, the heart probably takes a bit of a hit too. So there's a degree of myocardial dysfunction that probably happens to these patients. And so if you're in the critical care transport sphere, you might want to be thinking about, how does the heart look? And so more and more places are using point of care ultrasound in their transport teams. And so it might be an opportunity to quickly look at the heart and see, actually, maybe I don't need to continue pumping blood or blood products into this person, but maybe I need to be thinking about what drips I'm using for this patient in their transport to support their heart, to get through this. And this is like evolving kind of our understanding of the hemorrhagic shock patient, that actually maybe they do have a significant degree of myocardial dysfunction that happens from the not only the bleeding, but also the inflammatory hit that happens as a result of major trauma.
Yeah, and depending on how hypoxic they were, right? So the
Yeah,
heart doesn't like that either.
yeah,
But
totally.
you took one of my questions away from me. Was do we at what point do we start thinking beyond our ABCs, stabilize this kind of thing, and we start moving into more involved therapies? Like, at this point in the game, do crystalloids have a role? I would argue that if they're still coagulopathic, maybe not. But what about, and I'm shamelessly doing research for a presentation in Alabama, but what is the role of vasopressors at this point? Because they're
Yeah.
probably intubated, they're probably sedated on a shitload of propofol and stuff like that. I mean, it's almost necessary to move that patient, correct? We're not going to do that on blood alone, right?
I'm
Yeah.
so happy you brought that up, Cody, real quick, just because this is one of
Yeah.
my big questions that I had for you. Because diving into the physiology of shock and specifically like endothelial damage due to like hypoxia, that was my question. It seems like a very it's like a what do you call it? The seesaw, like it's a teetering thing, right? So I imagine that giving a catecholamine too early is going to certainly exacerbate and not be good. Because we're not getting oxygen to where it needs to be, and then we're going to perpetuate that injury. But on the other end, sometimes we might need that increased cardiac function. We might need that vasoconstriction a little bit after for those prolonged shocky patients that have those inflammatory markers running rampant. So I'm very excited for this question. I want to get your thoughts.
Yeah, no, it's a great question. And I think it goes back to what we understand about end-stage hemorrhagic shock. For years, people have asked the question, should we be giving pressors to trauma patients? And by and large, there have been a lot of studies out there that have kind of shown that, there's no real benefit to giving pressors early, or the traditional pressors that we talk about, which is usually Levophed, norepinephrine for people not familiar with Levophed, to these patients. And the studies were looking at, before and after appropriate volume resuscitation. And overall, they said, yeah, that's a bad idea. These patients do a lot worse when you give them pressors of that sort. But if you go back and look at the pathophysiology of hemorrhagic shock, especially as they kind of progress in it, you kind of understand what's happening a little bit more. So as people kind of progress in their shock state, typically we think of the body's response to hemorrhage as vasoconstriction, but towards just before they get into the kind of irreversible death stage, they start vasodilating actually. And so the reason for that is severalfold. So there is a release of nitric oxide, so that we know that's a vasodilator. There is actually competition at the receptors for epinephrine and norepinephrine. So as part of your fight or flight response, you already have a huge amount of circulating epinephrine and norepinephrine in your system. So that innate pressor that's there is fighting for receptors to get into the cell to do what it needs to do. And so it makes sense, right? If the norepinephrine that's already in your system can get in, then what's the point of adding external norepinephrine to it? But the third kind of process that people have really focused on more recently, and this was really demonstrated well in animal studies, was that there's a deficiency of vasopressin. And so the vasopressin, remember, is released by your brain in response to hypovolemia. It acts on your vessels to cause vasoconstriction, and it tells the kidneys to hold back on your fluid so that your volume is kind of restored to a degree. So vasopressin in animal models of hemorrhagic shock actually showed mortality benefit, and that was even when compared to other traditional pressors. And so there was a recent study that actually came out of Penn looking at the use of vasopressin early in hemorrhagic shock. So they looked at patients who'd gotten like the start of a massive transfusion, and they added X amount of vasopressin. Those patients actually showed decreased blood product requirement. It was pretty small trial, so they couldn't really show a mortality benefit, but nevertheless, kind of it showed you didn't need as much blood for them. And that, I think, is a win in and of itself. Not only because you're giving someone else's blood to this patient, so all the consequences of that, but also kind of the volume that's associated with it, et cetera.
So vasal,
So
go
go
ahead.
ahead.
So vasopressin may have a little bit of a longer onset time, correct? And is it prudent to maybe start with something else to maybe get some tension in the vascular system, and while you're waiting for that vasopressin to get started, bolus
Yeah.
dose pressors or something to that effect?
Yeah, so I think that's where we can kind of talk about, how much is the heart kind of contributing to this?
Hmm.
And so you might be thinking about, maybe giving some push dose pressors might be useful, especially if you have the added benefit of being able to look at the heart. So if you have some skill in doing point of care ultrasound, looking at the heart really, and you don't have to be an expert at it, just look at the heart and see what it's doing. And so if it's like not really squeezing well, then maybe you give some push dose epi, and that can help kind of get the heart moving a little bit more, as opposed to just flooding it with more volume, whether that's blood or crystalloid or whatever you have at hand. Because if the heart's not functioning, then your pressure's not going to get better, and the heart's just going to get worse. So certainly, I think maybe small doses of push dose epi in that instance might be beneficial as well, while you're getting your other stuff up. And then after the bleeding is controlled and they're in that shock state that's persisting, that's when I think using your pressors over volume resuscitation is probably going to be better. Certainly, you want to be correcting any coagulopathy, but it doesn't mean that you're letting the product without really thinking about it. Uh, but rather, titrating vasoactive medicines as well as administering volume to kind of maintain their perfusion, their cardiac function, as well as the vascular tone.
Hey, and
Yes.
real quick, I just want to, I don't mean to cut you off, Cody, but for the folks that are listening that might be lost right now, right? Because let's be real, we are in the weeds and we recognize we're in the weeds, but I really want to state that this is where the current research is. Is that correct, sir? Like, I mean, we are in the land of we don't know what the correct answer is, and we're kind of hypothesizing. And I imagine there's a lot of current work being done. So if you're lost a little bit, that's okay, because the people that are doing the research are probably a little bit lost too. And that's kind of the really cool part of all this, that we're really talking about the cutting edge stuff. So, Cody, I'll give it back to you. I just want to put that snippet in there real quick.
No, I think it's timely. The title of my talk is maybe it depends. I don't know. These are such great points, such great nuggets here, Doc. We so appreciate you spending the time with us on this. I want to take it one step further and get a little bit deeper into the woods. I get it, like I'm in the tall grass or the real short snout at this point. But so shock-induced endotheliopathy, or SHINE. It's something that I can't find a ton of research on. I mean, there's some out there and it's well described, but what we do about it is maybe it depends, right? How do at our at the critical care transport level, medics and nurses, how do we know, or how would we know? Hey, we're in this situation, and we need to talk about how we're escalating things, or what are next steps? Maybe discussions to have with with our medical directors and say, Doc, I think this is where we're at. And as those of us that are aware of this know that our pressors aren't going to do much in this situation, right?
Yeah, and I think it's as you say, it's a challenge to do, and in some ways, I think we get kind of biased somewhat to wanting to do what we think is the right thing, even when we start to see signs that this is now perhaps an unsalvageable kind of case. And so, and I think when you're starting to talk about the severe kind of endotheliopathy, then it's almost to the point where, despite the kitchen sink, you're not going to get better. So I think, in some ways it might be, taking the time to look at the course of events so far. What has the sending facility actually done so far for the patient, and maybe spending a minute or two just to evaluate the patient before you pick them up and making a joint discussion decision. What are we going to add in the transport, and what are we going to do differently for these patients than if you've already tried your level best to try and reverse the shock that's now become irreversible. And so, but you're right. I think it's difficult to understand when you reach that point sometimes, and especially if you're dealing with a young, otherwise healthy patient, you still want to try and throw a second kitchen sink at them and continue the care. And ultimately, I think this becomes a case by case basis. But probably talking to the sending facility physician as well as your medical director at that point, just to discuss and at least bring it up, would be useful. And because if you don't think about it, then you're just kind of going on automatic and just doing things that might not be ultimately beneficial to the patient.
Yeah, sure. You could take what once was an ECMO candidate, but with that 1-2% chance, and with your best intentions, take it out. Remove that chance from them, right?
And real quick, I just want to review what endotheliopathy is, because maybe people don't know what endothelial cells are. So we're just talking about that layer, that initial barrier in our blood vessels, that what cells are lining that's what we're talking about. For folks that may not know, I don't want to lose people on that, but no, thank you. That's
and
great.
It's where your receptors live, right, Moose?
Yeah, well, receptors live everywhere, but sure.
But so at this point, the problem that we're talking about with shine or endotheliopathy is the vasculature, or the body is now chemically and mechanically unable to respond or to do what we need it to do.
So the way I describe it is like if you're watching Lord of the Rings and the orcs are all over the walls. Yeah, the integrity of that wall is broken. There is no regulation. The gate doesn't work. Orcs are everywhere.
Yeah.
The one dude's jumping off the one tower. Yeah, it's not. That's what I. Yeah.
And that's why Doc is referring to it as irreversible shock. This is vasoplegia and distributive shock in this state is what we all call it. We all know as the final common pathway.
Yeah, Gondor's calling for aid and no one's coming. No one's coming. Yeah, we're it's a Friday 4. Yeah.
Friday 4.
Not have this conversation and not talk about these SPARC teams, okay? Because that's a cool name. I've already said it a couple times.
So we'll kick it back to the SPARC teams. Doc, unpack the concept and kind of your experience with them, or the perfect world situation or scenario for them,
and just define the term too, if you don't mind.
Yeah, sure. So SPARC came out the concept of from the military again, of advanced resuscitative care. So when we were talking about earlier about those the mortality benefit that happened over the 2 decades of the Iraq and Afghanistan wars, the group of folk that were most likely to still have potentially preventable death were those with non-compressible torso hemorrhage. So the concept for advanced resuscitative care, or ARC, was to administer blood at point of injury and provide some form of advanced hemorrhage control. We talked about Rabo in particular, but really there's other opportunities like the junctional tourniquets and things like that you could potentially use, but some form of that. So that's the concept of ARC. And so as we put this paper together for civilian world, we wanted to kind of balance the fact that the majority of folk who are injured probably don't need the advanced resources of, say, a physician or an advanced paramedic team that goes out, that has these skills, that go out to things, because I think that would not use your resources the best way. So we added the SP, selective pre-hospital. So for select cases, this advanced resuscitative care team would be able to adopt that scoop and control approach and provide those meaningful interventions and achieve those marginal gains, and bring that back to whatever facility you're going to. And in some ways, in some states, maybe that looks like the GOAT team, like in Maryland. In some other places, say Cincinnati, where they're using physicians in the field as well, or have advanced pre-hospital care. The concept is, identify the patients who might benefit from it, and then target your clinical resource and skills to that patient. And that's in the diagram that we showed earlier. They intervene at the point of between kind of the initial EMS response and before transport, and so that they can provide some on-care support, and also en route care. And so that's the concept of it. And so where have people been doing that? So I always kind of bring the example of air ambulance services in the UK and Europe, where and I would say in London in particular, this goes back to Mustafa, where you were talking about helicopters being a great way to bring the skills to the scene. If you think about it, on the face of it, you might think, why in a dense urban environment like London do they have a helicopter? And so the whole reason for or a big reason for their helicopter is not to transport the patient back to the hospital, but it's to bring the resource to the scene quickly. And so you can imagine trying to drive in the traffic of London in the middle of the day. It's really challenging if you're in a car and lights and sirens to be able to do that. But the helicopter is able to bring that advanced resuscitative care team to the patient very quickly, and then they might choose another mode of transport to get back to the hospital. So you're essentially shortening the time to meaningful intervention, again, by bringing that team to the right set of patients. So then you have to bring it back even further. How do you find the right set of patients? And that's, I think, where we really need to be thinking about how we're dispatching resources. And I think that's been a real problem in a lot of systems. One, again, because of the disparate nature of dispatch centers and how they're set up. We talked about in Philly, where police get the initial 911 call and then kind of bring it on to medical services as needed, and that's perhaps too late. And then also, what is the experience of the call taker? So are they just following a script on like a CAD system, and they're just saying, okay, if they say this, then you're going to do this, or are they thinking about what's happening? So if you look at these systems that are doing it well in Europe, in particular, I would say I went to and looked at their dispatch centers. I looked at the dispatch centers in London, and I looked at the dispatch centers in Paris, where they have kind of these advanced teams. And they actually rotate their clinicians through the dispatch center, so that the experienced clinician, and in some cases it's a medic, in some cases it's a physician, is listening to the call. And again, going back to experience matters, they can perhaps pick up the nuance of what's in the caller's voice, or some particular terms of, hey, this scene sounds like it's much more complex than what someone with less experience might think about it, and I'm going to target my resource to this scene. And I think that's really been a key to the success, because you could have the most advanced team in the world. If you're sending them to the wrong place or too late, then they're no use. And so you're missing that window of opportunity to make change. So that's another element that we really should be looking at improving upon. And I think we can, as the technology improves, I think there's more and more ways to do that. You now have like apps where you can send links to the 911 caller so that they can you can tap into their video feed and actually look at the scene and say, hey, oh yeah, that looks pretty bad. So they might benefit from having this SPARC team go to them. And so I think there's a lot of opportunity that different systems can do to do that. Maybe it's the supervisor, the paramedic supervisor who makes the call that, actually for this call, we're going to dispatch this resource and utilize that. So depending on your system, you can make it work in several ways to be able to use that SPARC team.
Good, Cody. Because I got a whole thing on this. So go ahead, bud.
No, go for it. Drive on, man.
This is this is where I thought a lot about this paper, right? So you mentioned the air ambulance service, and you guys you certainly mentioned what I'm about to say in the article. But I would argue that the bulk of this paper, right, that your paper is dependent on what I'm about to talk about, and that's the funding. Let's be real. Like all of the clinical stuff, everything that we've talked about so far is imperative on elected officials and policymakers creating a sustainable environment where we can do this, right? So I guess my first question is, it's certainly good to use London as an example in terms of operations and how they do it, but certainly it's as soon as we try to look at how they fund it, everything falls apart. So what are some what advice do you have for those policymakers? What advice do you have for the folks that are talking to the policymakers to get this this ball moving?
It's a common question, and I think it's a real important one because even especially I think in the current environment, there's a lot of EMS agencies that are struggling just to provide their routine care. And so, being able to fund this becomes even more important. So let's look at the London example. And in fact, I would look at the air ambulance services that are outside of London. All of them receive no funding from the National Health Service, which is the government. And they all receive their funding through charitable donations. And so you can imagine that, they do a lot of work trying to get those donations to provide their service, and they're up and running 24/7. So they're clearly getting that. And so that's partly by showing the public that they're a resource that's worth investing in. So that's one way. But that's, that relies on kind of that concept of community and things. And so we know sometimes that can be a challenge. So, when you say you can't do this in the United States, I'll give another example where in Minneapolis, they decided that they would want to get people onto ECMO faster for out-of-hospital cardiac arrest. But again, they had so many different EMS systems, different healthcare systems that were kind of essentially, in some ways competing as businesses for the pre-hospital work. So how do you get them together? So again, there's a great paper that actually describes how this group of clinicians went to city government, went to all these different EMS agencies and showed them that, this was a benefit to do, and actually got them to come together to be able to fund that service. What's a third way to do it? So look at Maryland. So if you get injured in the state of Maryland and Maryland State Police comes to pick you up and takes you to shock trauma, you're not going to get a bill at the end of the day. Why? Because it's paid for through the $3 or $4 that you pay every year to get your vehicle tag renewed. And so that's a small cost that provides huge benefit to the residents of the state of Maryland. And so that's another way that you could fund a service like that. So again, it requires a little bit of thinking outside the box, but I think there's a lot of examples around the country that you could use to adapt to within your own system to be able to get the funding that you need. And it might be a combination of 3 or 4 different ways to do that. So, if you want to do it and you show that the data in particular, people can't argue against data, right? So you show them that this is beneficial, then, and you find a champion to help you with your cause, you can actually kind of move the needle on these things.
Come on, Doc, you're on Instagram. You know people are arguing against data all the time.
Yeah.
And I really appreciate that.
Balance.
And the and especially like in the paper you talk about the ET3 model, the emergency triage treat and transport model that was rolled out. I mean, we all know how that ended, but
Yeah.
I think the way I think about it is it has to be a Swiss cheese model, right? Like sure you can have a foundational funding source, like you mentioned for the EMS operational fund model, right? So I think that my frustration for this comes from the fact that I feel like we as an industry, not an industry, we as a profession, not just paramedics or EMTs or physicians or everyone that deals with, the 28-year-old patient that just got hit by a car, everyone that's involved in that care, we are stuck in like third gear and we just can't move forward. It's not just trauma. It's not just medical stuff. It's not just like, we are stuck. And, for me, and I don't mean to bring this back to the whole paramedic practitioner thing, but we talk about reimbursement. We talk about like models of care where we have to have a middle ground between like the paramedics that we have functioning today and the physicians that will need to move out. I can't help but think that if we had a middle tier that was reimbursable, right? That was billable for lack of the issue. If we had federal funding that provided for reimbursement, like you're talking about, and programs that we're talking about, I think that would be good. The reason things are the way they are, and I've said this a million times on the podcast, is because people just like us had the courage to move forward, right? And that's empowering because it allows us to feel that we can make the change, but then that change actually has to happen. And that's not necessarily a question. That's more so just a comment and really a view into my frustrations, right? Of everything here in this paper says that we know what the right thing to do is. Yet where are we?
Yeah.
When did you publish this? 2021, 2022?
Yeah, it's been
Right.
a couple years now. Yeah. So
And to be clear, a lot of the initial research you said was paid for in the price of our servicemen, right? Our servicemen and women, right? So certainly this was not free. We've learned a lot of these lessons. And I know we don't have the answers, but I mean, especially to the folks that are listening to this, you shouldn't be leaving this just, thinking about it as another podcast you listen to. You should be listening to this as how can I move the needle forward?
yeah.
That's the point of why we do what we do here.
Yeah. And there are wherever whenever you're trying to bring about change, you're fighting not only the process, but more importantly, you're fighting culture, right? And so a lot of places saying, well, we've always done it this way and it seems to work, so why should we change? And fighting culture is I'd say 20 times more difficult than anything else. But I would say there is something to one, having someone who's going to stay and champion things, champion change. And two is persistence. And if you're looking for a quick return on your investment, then perhaps this is not, perhaps you're not the right person to kind of tackle this, because it will take a bit of time. Sometimes it takes much less and sometimes it takes much more. I'll give you the example of, our change to state protocol for pre-hospital blood in Pennsylvania. We thought it would take a long time to kind of do that. And it was like, but actually, there was a group of us that really kind of got together really quickly to kind of put the data together for this. And we did it at a time where we aligned with the general thoughts of the state medical director. And so that timing worked out. And perhaps, if we'd tried to do this 3 years ago, maybe we wouldn't have been accessible, or it would have been taken more time, and vice versa. But again, it requires you to, one, have a cause that you are willing to champion, and also the persistence to be able to move forward with it. And that's where you ultimately will see gains. And if you're trying to change the whole system, then that's not the right thing. But if you come to your medical director or your fire chief and say, hey, I just want to do this small change and see how it works, that can be the start to it. And then everybody's starting to do things that way, and they think, okay, now that we're done this, let's try this small step. and maybe it does take 5 years or whatever. But ultimately, you're now changing culture, and that's really kind of the approach that I think you should take with it, regardless of what kind of model you're working in, because ultimately, the that cultural change, once it occurs, is difficult to then, once you start changing it, then it's difficult to stop it.
Man,
I love it.
what a note to end on. You know, once you got the momentum, it's really hard to stop the train.
Yeah.
Wow. Moose, did you have anything else for him?
No, this was good.
Josh, do you have any final thoughts for
No,
Dr. Qassim?
you guys kind of said everything. Honestly, this was great. Plain and simple. It was great. Great topic to bring up right now. And yeah, man, Cody, I'm gonna let you take it out just because I don't have my video up now. But when we're ready, it's you, man.
Dr. Qassim, we appreciate you taking your time to talk to us about, I mean, everything that we've talked about. Apparently all aspects of trauma care were on the agenda today, and I appreciate you humoring us of going a little bit off script, and just being so engaging with us in answering these questions. I see another podcast in your future if you're available. And man, I really appreciate it. And so for all our listeners out there, wherever you're at, whatever time of day that you're taking this in, we appreciate you just as much as we appreciate Dr. Qassim's time. And Dr. Qassim, where can folks find you out in the world?
Feel free to hit me up on Twitter, or X. It's at Resus1, RESUSONE. That's probably going to be the best way to kind of get a hold of me. You can DM me, or just tweet at me, and I'm happy to get in touch with you, or look me up on LinkedIn as well under my name. Feel free to post regularly on there too. So those are probably the two most reliable ways to get a hold of me.
Excellent. Thanks again, Doc. And on behalf of the entire Alert Medic One team, this is us signing off saying bye.
Great. Thanks so much.